were treating acute myeloid leukemia with 7 and 3 in 1977. Today in 2019, we are still doing the same. What is the best way forward to change it by 2029?
So there are two issues, I think, that you're touching with this question. The very first issue, which could be more relevant to basic science researchers like I was, is awareness. So I think there is a lot of us, and myself was included in that several years ago, before I became acquainted with you and with some other colleagues who are actually MDs and see these patients, who don't really realize how far back we are in terms of treating these patients. We, especially as basic science, we live in a world where currently there seems to be a big revolution. Precision medicine, exome sequencing, identification of most common mutations which are tremendously significantly related with certain groups of MDS or AML. And even in some cases, some drugs that are designed to treat these mutations, FLT3, IDH1 and IDH2 mutations. And we very often get the feeling that we are moving ahead, and in some ways we do, but not as much ahead as we think we are. So in spite of these discoveries and in spite of some new treatments, I don't think that all basic scientists appreciate how much of the most common way to treat this disease is still as it was 30 years ago. And how, as much as good and promising they are, these new discoveries, how limited they still remain, and how overcome they can be by the plasticity of the tumor cells themselves. So that's one big issue. The other one is that, well, maybe we are losing something, maybe we are missing something still in how we look at the disease, how we understand its biology, and perhaps what systems we use to understand its biology, and what systems to use to test it and test it against specific treatments. So maybe there are points we ignore, first of all, to begin with. That's where I come from. So for me, understanding the host better, not only in terms of its myelodysplastic cells or its leukemia cells, but in the context of where these cells live and how does this context affect them, like the microenvironment. The bone marrow stromal cells, the immune cells, is something that should be done more and to a larger scale, and it should be taken more into advantage, and we should all start thinking about treating these outside signals. I mean, if you think about it in the end, if you treat a signal that originates from a cell that doesn't clonally evolve forever, you may have a more stable target to devise a new treatment. And the other thing is, maybe we should put a lot more emphasis on understanding the disease in its natural host, which is the human, the patient, and think about how we can devise systems that can study the disease better in this particular host. Animals have been helpful in the past up to a certain extent, but definitely they do not tell us a lot about the human disease, and we should be doing more and devising more systems to study it in its normal origin and its where it exists and basically thrives, which is in patients.
Excellent answer. No one has brought up that first point that you made, which is
the awareness,
the awareness and education about from the clinicians. So thank you so much, Stavroula, for a really superb answer. My second question is, there's a 3.5 million papers on cancer, 135,000 in 2017 alone. There's a staggering disconnect between great scientific insights but translation into improved therapy. So what are we doing wrong?
this is a tough. It's always a tough question to answer. So that's a little bit relevant to the first question and part of my first answer, that cancer is such a complex and multifactorial disease. So when we take it out, mutation by mutation, on top of it in a system that is not human, that it is a rodent, we're running a big risk of misrepresenting it, of not understanding well, especially its initiating biology, what it is that it initiates it, and not studying it in the right host on top of everything. So there is 3 levels of difficulties and 3 levels where we can really misunderstand observations and results. And then there is the 4th level, which is once we have these observations, once we have our mechanisms, we have our mutations, how do we know how to treat them, and if the treatment we give is really as effective as it is in the mouse as it would be in the human? So I think all these are really difficult questions that again bring up the idea of study the disease in patients as much as you can. And the other problem is that we've always hoped, and we lived with a dream, I have a dream that we are going to cure cancer. And maybe there will be a time that we are going to cure cancer, but right now maybe we should really focus on predicting cancer, on catching it in the earliest stage possible, on really, we're looking for all these initiating mutations and we still really don't have them. Maybe we should really identify them and catch them right when they start at the very first cells that erupt and spread, and try to find ways to isolate those and good ways of targeting them. And that's a big problem because it means we may need to target first cells with first mutations in people who still are healthy. So that also brings a new ethical problem and a new difficulty in dealing with the disease. But I think, especially in our field, with the discovery of things like clonal hematopoiesis and the first mutation, it might be the right now our best chance for dealing with the disease.
The fact that children respond to the same treatment better than adults seems to suggest that the cancer biology is different in the two. But also the possibility is that the host is different. Since most cancers increase with age, even having good therapy may not matter because the host is decrepit. Your solution?
My solution is, again, that you have to study the biology of the disease within the right context. So in an adult, the context is aging, and hematopoietic aging, even bone marrow stromal cell aging, is a completely different story and a completely different biology from a developing hematopoietic system or a developing bone marrow stromal cell system, which is what is happening in a young kid. So, as we were discussing before, and many times, a young child may have the ability to, rejuvenate part of its bone marrow system. It might be able to respond better. Clones may not be so stable, whereas when you've aged relatively to that, and your hematopoietic stem cells do not have the ability to differentiate that much anymore, they become senescent. It's a whole new biology that needs to be looked at exactly there, and a whole new way of how to treat. Even if you find the same causes of the disease, the treatment might need to be different for sure.
Makes sense. Thank you. Fourth is you have a lot of experience and knowledge in the field. If you are given limitless resources, how will you plan a cure for cancer? What will you do?
So what will I do? I think I would try to open up my mind and put an effort to fund and to put money in things that wouldn't normally be funded. I would try really novel ideas that are as people call, out of the box. I think we need to be a little bit more risky in biology, asking a couple of more risky questions, what others would call wild ideas that are not usually what is funded by sometimes the NIH or foundations or other resources of fund, and I would go for that. And just because of where I come, because this is what I would do, I would really look. I mean, again, we've been focusing on cancer cells and their hyperproliferation as all events that are happen within the cancer cells, and where are these influenced by? So I would put a lot of effort in the environment, whatever this environment or microenvironment it is. I would look for new ways and new interactions between the cancer cells and their healthy hosts around them. And I would try to find novel interactions and novel biologies with them. And I would still put a lot of effort, again, into identifying the earliest possible stage of these cancers and how that could be promoted, amplified, selected, whatever it is, by this microenvironment of the eventually mutant cell that becomes the cancer cell. That's what I would try to do.
Love your answer. Too early, right?
Yeah.
Okay, so last question, Stavroula, is a little bit of a philosophical one, but it's one we all face, whether we are doctors and oncologists or family members of people who are going through the cancer tragedy. Offering patients with advanced stage, non-curable cancers, palliative but very toxic treatment, is it a service or a disservice in the current paradigm?
So, I've thought about that many times, and every time I think about it, I try to put myself in the place of the patient, and then in the place of their family, and in the place of the doctor. And you can see that all these three different groups can have so many different angles. Okay. So I think if there is a decent way to go about that, is that every patient who finds himself or herself in such a difficult situation, and their family and friends, deserve to know the reality, deserve to know the whole truth, how painful or not painful it is, no matter how painful or not painful it is, on what the treatment option is, but also what this treatment translates to, how invasive, how debilitating can the treatment itself be, and what are the other options. And they should be as well informed and they should be presented in a way that they can really have a choice between taking this treatment and hoping whatever it is that they hope, but also choosing not to and live a last stage of their lives in a way that a lot of people, if they have the right information, may actually think that is less painful, more decent, and less offensive. So I'm sure there is patients who would do either. There is those who would want to fight until the end and hope there might be a miracle or an exception. And there is those who think, no, I want to live my last months of life in a different way. For me, that treatment is an offense. It's not worth for a human being. So I think the situation should be presented in an equal way where they can make this choice. And not only in a way that, yes, we will fight the cancer no matter what. Because that's not the case.
Beautiful answer, all of them. Thank you so much, Stavroula. Really appreciate the time. Thank you and have a good day.
Thank you.